HIV patient, most people, or you have leukemia or something like that, most people will respond to the yeast. So it seems a little weird, but there's been a long evidence of efficacy and for actually injecting the warts with the little yeast. And what happens is your body then recognizes and associates the virus with the yeast. Well, your body is going to react to the yeast, but your body didn't know the virus was there. That's why the wart was still sitting there. So you can inject just a couple of warts, and if you have 100 warts, they'll all melt away. So it's a series of injections that has been used for a very long time, and it's extremely effective. And injecting warts is often less painful than freezing. Most kids will tell me it's less painful than freezing their warts. So it's a great method of boosting the immune system against warts. There's other treatments as well. We often give them pills to help. Actually, there's an antacid we use, Tagamet, you've heard, which also boosts the immune system. So there's a lot of different ways. And then laser treatment. There is a laser that is usually a pulse dye laser. You ever notice that warts have a very good blood supply? So sometimes cutting the blood supply or suppressing the blood supply actually helps the wart go away. So there's been a lot of evidence that some of the vascular lasers have a very, very good response to, or the warts have a good response to treatment with the vascular laser. So Dr. Citron is bringing a 1064 YAG, which is a vascular laser, or it can be used as a vascular laser. So that may be something we're also going to be doing as well. So anyone know what this is? Atopic dermatitis. And the other name for this? No. Eczema. So atopic dermatitis is eczema. And this is very common. It usually starts about 3 months of age. So parents come in and they have a 6-month-old baby and I say, it started around 3 months. They're like, how do you know? Well, I'm not a mind reader. It's actually, so that's really common right about when the immune system starts revving up. After the babies are born, it's about 3 to 6 months, the eczema flares. It's generally a genetic condition. It's sensitive skin type. It gets better as they get older, generally, and often these kids do very well just with topical steroids. But it's a matter of figuring out the right strength and just educating the parents about how to take care of these kids, because their skin is going to be different than people without eczema. So we do topical steroids. We really talk to people about taking sensitive skincare recommendations, not overbathing the kids. Using fragrance-free products, because these kids are very sensitive to anything with fragrances and dryer sheets and softeners, that kind of thing. And then often with eczema is the reason it flares is infection. So we take care of the infections, and then just telling parents how to prevent infection, again through general skincare. And then often if these kids are really, really severe, sometimes they do need oral medications. Okay, so this is psoriasis. Many of you may know this. And some of the different treatments of psoriasis, simple would just be topicals. Other medications are oral medications. If it's very severe, covering half their body, you might see somebody on methotrexate, which is a chemotherapy drug, but it's also used to suppress the immune system, and at low doses can be very well tolerated in psoriasis. Other treatment options, I'm sure you've seen some of these commercials where people are running through the fields for Enbrel, which is infliximab, and Humira. There's a lot of advertisements out. These are injection medications that suppress the immune system and work for severe psoriasis, where this is covering over 50% of their body. There's a huge quality of life issue. So it really depends on the person, because some people can be covered 90% in psoriasis and they don't care, and then some people it's 30% and it's extremely distressing. So it's one of those things. So I do all that kind of thing. I manage this medication. I have no problems, very experienced with it. The only thing that I don't do, and we don't do obviously, which is we don't do light treatment. That means we don't have a light box where people go in, and sometimes psoriasis is treated with light treatment. We live in California, so often you can just get a little bit of sun, because sun makes psoriasis better. But in the old days, people would take pills that would sun sensitize them and then go in a special box with a wavelength of light that will also help that, especially on the East Coast. But the problem with that is that after a certain number of treatments, it also increases the risk of skin cancer, which makes sense. But anyway, that PUVA has fallen out of favor, really, so it's not done as much. Usually the only people that have the light boxes anymore are either some of the older dermatologists or universities, for the most part. So there's very few dermatologists in this area that have light boxes. In fact, I don't know of any in private practice in this area. So they would have to go. they would have to go to the university.
What are some of the topicals that are used?
So topicals, we use usually high-strength steroids and vitamin D creams called Dovanax, if you've heard of it. Or it depends, again, on the area. That's how you would choose the strength of the steroid cream. But the mainstay would be steroids, vitamin D. Sometimes you can use retin-A's to thin, like in this area, you would want to use, let's say, a retin-A to thin the skin, and then use a steroid to then penetrate into the plaque because it's so thick. That's going to be the most part. And then there's Protopic. There's also non-steroids we can talk about later, which are also used for the skin to as an alternative because it doesn't overthin the skin. So this is vitiligo. So obviously in darker skin patients, this is more concerning and more disfiguring because it's so noticeable. There's a lot of patients like that would be, let's say, my skin color or Bonnie's skin color that had vitiligo on the face, and you would never even notice because they're so fair. The white, as long as they stay white and don't get tan, in other words, you're not gonna really notice it's very easily covered up by makeup. It's not very noticeable. So here again, we do treat these areas with steroid creams. In this patient's case, you wouldn't want to put steroids around the eye. Most of you guys know that because of ophthalmology, because it increased the risk of cataracts and glaucoma. So what would we do? We would put a non-steroid around the eye, something called Protopic. Elaine, what do you know about Protopic? Have you heard about that? It's called topical tacrolimus.
No, I don't remember. I've heard you talk about it before.
Yeah, so Protopic is it's an immunomodulator. It doesn't suppress the immune system, and well, the good thing about it is it doesn't overthin the skin. It does have a black box warning on it, which is something we always discuss with patients. And what that means is if you feed it to rats in large quantities, they can get lymphoma. Well, don't feed it to rats in large quantities. Basically, the point is that it's generally very safe, but it's often used in IV doses for transplant patients. So when it's used in very high doses where you're getting systemic absorption, internal absorption, then it can suppress the immune system. Anything that suppresses the immune system can let cancer grow. That goes for steroids as well. But when you're putting topicals on small areas, chances of really having any significant systemic absorption is very low. So chances are you're not getting anything absorbed, you don't have to worry about it. It's very safe, even in small children, and I use it all the time. But it's one of those things that go to the pharmacy, the pharmacist says, this has a black box warning on it, and then the parents get nervous, so you have to educate them ahead of time.
What was the abbreviation that they have used in the previous slide for light therapy?
PUVA, which it's Sorolin and then UVA, ultraviolet A. So it's a light sensitizing medication in combination with ultraviolet light. But in California, a lot of people, when they're treating psoriasis, they say, go get 5 minutes of sun a couple times a week. Don't burn yourself, because then your psoriasis and vitiligo is going to get worse because it shows up in areas of burns. But get a little bit of sun. The sun suppresses your immune system. So that's why it works in these conditions. This is an autoimmune disease. So somebody like this, I might do blood work on because this is linked to thyroid disease and other autoimmune diseases like diabetes. So sometimes you check this and they do have some risk of either developing thyroid disease in the future or having it if there's a strong family history.
Now, are you putting the cream on the dark part, the light part?
On the light parts, on the light parts. And what you'll see is when this comes, so most of the time, this comes back. It will come back in little brown spots around the hair follicles. But in some patients, let's say they have a stable area that has not changed, like a big white patch somewhere, it's not changed in 5 years. Well, chances of getting that patch to go away is going to be low. So what sometimes we do is we take a little piece of skin from an area that has color, and we put it in the area that's white, and it will regrow from there. So what happens is that around the hair follicle will start the pigmentation, and you get pigment around where it's a little transplant. We call it punch grafting, like the little baby cookie cutters we use. And it's so small you wouldn't even have you wouldn't even see a scar. So that's often done, let's say, around the eyes or in areas that are very cosmetically sensitive, and that they have not had any change or improvement with other treatments previously.
So you put the cream on the white part, and they would change it back to brown?
Mm-hmm. Ideally, in a perfect world, if it
Is
responds.
this your
But a lot of
patient?
people treat, especially in the face, it usually responds quite well.
Is this your patient?
No.
Did you just say the sun suppresses your immune system?
Yeah.
So this is onychomycosis, so that's fungal toenails. But sometimes you can't tell the difference between fungus and psoriasis. So what are the things that we do? We take nail clippings, we send it for culture, we make sure it is fungus. And then what do you have to do? Do you have, well, you know, sometimes my husband's had ugly toenails, I'll talk about him, for, 20 years. And he doesn't need to treat it. For him, it's cosmetic. So the question is, when do you need to treat and why do you need to treat? Well, for diabetics, if they get fungal infections on their toenails, it brings in bacteria. What happens to a diabetic if this gets bacteria on their toe? They lose the toe. So that's why you want to treat diabetics. So those are the cases where it's absolutely necessary. And it used to be that Lamisil, which is an oral medication we use for that, it was extremely expensive, but it has become generic in the last, I would say, couple of years, 2 years probably. And so now it's very reasonable. I think you can get an entire 3-month course for, I think it's $10 at the Walmart. At least it's only a $10 copay per month, so it's $30, $40. It used to be $5 a pill, so it was $450, $500 for one 3-month course. So anyway, so if you do want to treat it, and obviously if you're young, let's say you're female, you don't really want nails looking like that either. So if you're young and healthy, it's easy to treat. It is really more of a cosmetic issue, but we can treat it with pills. Topicals don't really work well on the toenails. So sometimes the podiatrists love pulling the toenail, so that's an option. And sometimes they hope that it grows back normal. Sometimes it doesn't always grow back normal. So I do that as well. I can get a toenail off in about 60 seconds. So there's other reasons why people might want their toenail removed. Let's say pincer toenails, ingrown toenails. So we can either remove them or we can even shorten them. So the reason people get ingrown toenails is because the bone is actually abnormal and their nail grows like this. So what you do is you actually just cut the sides and you destroy the nail at that location and you just make them a narrower nail so it doesn't keep growing into the skin on the edges. So that's a very easy thing that I do all the time. And so I take care of lots of toenail issues, lots of things in that area. And then back to the fungus, again, we talked about how the topicals really don't work well in toenail fungus because it doesn't get into the nail. But the laser that has come out, the laser treatment for fungal toenails has been fairly new, one of the newer things that's been in the last couple of years that's come up. And that creates holes in the nail so it allows the medicines to penetrate better. So you can do that instead of taking the pills. And some people would say, well, the pills might be too risky because it can affect your liver, or maybe they're on a million other medications it interacts with. That might be a reason why you would choose the laser. I don't think the laser is covered by insurance, but we'll have to kind of see what's being done right now and what the cost of that is. So that'll be in the works, and you guys will get some emails about that. This is the laser we would use for fungal toenails is the same one that Dr. Citron is bringing as well, which is the 1064.
Excuse me, so did you say you use both topical and oral medication for that?
Topicals don't really work on toenail fungus, but some people do it. There's some topical medications. There's the toenail polish that has a little antifungal in it. It doesn't really work, about I think 20% efficacy. So it probably works as well as Vicks Vapor Rub or whatever other homeopathic toothpaste. I mean, I've heard patients tell me they do anything to their toenails. So the topical stuff really doesn't work well. So, but the oral medications work great. But they are putting you at risk, but we do monitor them. We do blood work to make sure everything's okay. And in young, healthy people, I think it's very, very low risk in those patients. Okay, so alopecia, hair loss again. The little girl with most of her hair that fell out. Actually, this was due to a fungal infection, so we're going to give her some antifungals and she'll get better. But really, so how do we figure out this is a fungal infection? So sometimes there's a hormonal lab workup. If you have thyroid disease, you can lose your hair like this. So we do culture sometimes. We send I send a little bit of hair and a little bit of scale to the lab, and it takes about 4 weeks to grow out that, and then tell me exactly which fungus is causing it, because that'll help me decide which medication to put them on. And then the other thing I did, I scraped a little and put on the slide, and I went and looked at under the microscope, and I saw tons of fungus. So the fungus lights up in little hyphae and shows you right now. You're like, oh, it's fungus, great. I got my diagnosis. I didn't have to, do any stitches or skin biopsies, just got a little bit of hair. She was